more weight with bypass compared to sleeve?
Yeah, that's a great question. The short answer is yes. On average, over thousands of patients, and you can see that in our own BSR data, and even with trials. There's been trials, particularly in the UK, comparing sleeve to bypass, that patients with a bypass will tend to lose a little bit more weight. Now, we're talking a few more percent, so around 2 to 5% total body weight loss over that sort of 3 to 5 year mark.
Okay.
However, having said that, these are overlapping Venn diagrams, as in some people do amazingly well with a sleeve and some people really struggle to lose weight even with a bypass, and vice versa. So yes, as a general guide, people will tend to lose a little bit more weight with a bypass.
Yep.
But that doesn't mean that everyone loses more weight with a bypass compared to some patients with a sleeve.
Yeah. Yeah. I mean, and I think for Tash and I, where, you know, it's a good example. You know, we both lost around 100 kilos.
Yeah,
I had sleeve, Tash had bypass.
exactly.
So, you know, it is possible. And I try to encourage people that if they're sort of really worried about that, you know, the sleeve is still an effective tool.
Absolutely. Yeah. And I think it's a common question that I get asked, and I actually do show a lot of patients the BSR data. I think it is quite a useful resource. It is Australian data. It has good follow-up, and it provides a guide, you know, and if you do have a look at those numbers, they're within sort of 3 to 5% even after 3 to 4 years.
Yeah. Wow.
We've actually just had a question come through. How common after a sleeve is a twisted esophagus?
And after a sleeve?
Yes. And how is that, and if it occurs, how is it bypassed? That's the question. I'm
not too familiar with the term twisted esophagus after a sleeve. Mm-hmm. So yeah, I'm not so sure about that terminology. So after a sleeve is removing around about 70 to 80% of the stomach. The esophagus and the gastroesophageal junction is not changed in its continuity, but the fundus of the stomach, that greater curve of the stomach, is removed. And so the GI tract is in continuity. It hasn't been changed. I wish I had some of my diagrams up. But
yeah, we'll have to do that next time, Dr. George.
That's right. Yeah. Because I do. It's quite a sort of visual operation, but twisting of the esophagus is not a phenomenon that I've encountered, I have to say.
Well, that's good.
Twisting of the sleeve can happen. It's very rare, but it can happen. And you'll find some surgeons pexy it down or stitch it down because you are changing the anatomy of the stomach and disconnecting it from the omentum that holds it down in place. So, but not, again, the most common thing about surgery is that it's always done slightly differently. So you will find that not everybody does that. Yeah.
Yep. So what about with, I guess, some of our mature members, patients, people that we see? Is there a particular surgery that might be better for someone, you know, who is a senior, or is it really dependent on the person?
It's dependent very much on the person, I think. Yeah. You know, there's a sleeve, there's a single bypass, a Roux-en-Y that makes up, you know, 98% of all surgeries done in Australia. And the reason for doing one of those three operations will vary, and the ethos or the rationale behind doing one of those 3 operations will vary. If you talk to 10 surgeons, you'll get 10 slightly different answers.
Yeah.
But, we all think we're doing it for the right reasons, I think, or, and you have to talk to the patient as an individual and figure out what suits them best. Complications after a sleeve are less common, but they might be harder to deal with. Whereas complications with a bypass might be slightly more common, but they're generally more straightforward to deal with. So, the more you think about it and the more ways you talk about it, the more confusing it gets, I think.
Yeah.
So.
I suppose that highlights an important point, is that if we do have something going on after we've had a surgery, we need to keep that communication with our team.
So important, and always reach out, always come back. I think it's so important. Yeah.
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 Obviously, we get a lot of questions about long-term concerns associated with having a surgery done, which I understand. I mean, when I went into my sleeve, I never bothered getting my reflux sorted out, and now I'm paying the price with having teeth and all sorts of issues.
Yeah.
What are some of those long-term issues that we might see from some of these procedures?
Yeah, absolutely. I will say that on the whole, they're very safe and the outcomes far outweigh the risks. But there are risks. Like anything in life, there are risks.
Yeah.
There are the acute or the immediate risks, infection or leak and bleeding and hernias and things like that. And I think one of the participants has replied in regards to one of the chats. So we'll talk about that maybe after this. I think long term, one of the very common ones is reflux. Reflux is something that I, deal with every day, like most surgeons, and it's hard to pick. It's hard to know who's going to get reflux. There's no rhyme or reason to it. It can just happen, and you can have reflux even with a bypass. It's just because you have a bypass doesn't mean you don't have reflux. You're far less likely to have reflux, but it can happen. And I think that's quite an important thing to talk to your surgeon or your medical team about, and to try and seek guidance as to potential options, whether there's a hiatus hernia or whether there is twisting of the pouch or whether emptying isn't quite as good as it could be. Other long-term issues are nutritional deficiencies. So it's really important to talk to your team and have regular blood tests, take your multivitamins, make sure you take those, make sure you get your blood tests, 3 monthly in the first year, maybe 6 monthly in the second year, and yearly after that is sort of the guidelines, ASMPS guidelines that we are guided by in our clinical practice. And I think, that's really important, and we see it a fair bit, things like calcium, vitamin D, B12 and iron commonly needing to be replaced or supplemented, and it's important to keep a check of those.
Yeah.
Other issues, we can potentially weight regain. Nobody is immune to weight regain, and I think that's something that we need to, keep an eye on as well, and providing good dietary advice and support when there is weight regain, and reassessing where people are at. And I think resistance training or weights training is so important to help with limiting weight regain as a problem, increasing your basal metabolic rate, keeping that muscle mass in check is so vital to making sure that you don't have weight regain, or you try and limit it as you can. And then, we have the more rare things. So, if with a gastric bypass, things like internal hernias, which can occur and can be potentially life-threatening. Stomal ulcers, so ulcers between the bowel and the stomach. They can bleed, they can perforate. You may need an operation for that. And then even more rare things. So there's theoretical risks of cancers that can be missed because you have a bypassed, a lot of your stomach. You can't have a look at it and things like that. But I think those are very rare, and we're probably decreasing the rate of cancer more than the likelihood of missing something. So we're always doing something, and there's always a risk and a benefit, and we're always trying to weigh those benefits up and whether the risk is worth it.
Yeah. I think so often we hear people that, they feel like they've failed in their journey. They mightn't get to a goal weight or whatever the case is. But am I right in saying that weight loss, sort of any amount, is actually quite beneficial for us?
Exactly right. And I talk to patients about this. I don't think the word fail is the right word to use. I think I talk about weight management and weight struggles, and I think about weight management like cancer treatment. I've stopped doing cancer surgery because I think the benefits of weight loss surgery far outweigh any benefits of cancer surgery, and it's a bit of a harsh and cruel thing to say, but I think it's the truth, and when surgeons talk about recurrences after cancer surgery, no one goes, "Oh, that was a failure." No one thinks about it as a failure. They go, "Well, what are our options? What are we going to do? How are we looking at this? What's happening? Are we going to use more surgery? Are we going to think about chemo? Are we thinking about radiotherapy? Do we have immunotherapy? Do we have targeted, beads or other modalities? What are we doing about it?" We're not thinking about, well, that was a failure. Shouldn't have done that. That was silly. Nobody thinks about cancer like that. And I think that's the kind of conversation we have to think about for weight management.
Yeah, because I guess it's only more recently where obesity is becoming more understood as a disease and not a lifestyle choice.
Exactly right. And, I'm in South Australia. In South Australia, obesity is the number one preventable cause of early death. That's as of last year.
Wow.
Because of that, our life expectancy for children born from 2023 onwards is less. It's on the downhill slide because of obesity. So it is a real disease, it is a real problem, and it is one that is limiting our lifespan. And I think we need to look at that as a problem that is not going to go away, and one that needs to be treated as a chronic disease.
Yeah. So what are the and we have had people asking questions, and I'll get to that. But what is the options then if someone has had a regain? Because we've got so many more options and so many more tools available to us.
Yeah, we do. I mean, the big change is medications, injectable medications. It's really provided a effective option for people with weight regain, and I think that's a good opportunity to use medications. But I think before any treatment, what I go through with the patient is, how are we optimizing your weight management? How are we optimizing your situation on a daily basis? Are we looking at your daily routines. Can we optimize that with the dietitian? How long has it been since you've been reviewed with our dietitians? That's step one. Step two, are we engaging with you effectively in regards to resistance training, weights training, regular exercise? And don't get me wrong, the eating less and running more is not going to happen. However, on the flip side, I think you do need to move your body. You do need to engage in weights training to preserve muscle mass, to make sure you have that good outcome and resist that weight regain as best as possible. You're having enough protein, so important to keep feeling full, to nourish your body, build muscle, so important. After that, are you sleeping well? If you have a CPAP, have we looked at it? Have we interrogated it? Is it working effectively? If you do shift work, or is there a way around that? Have you ever thought about not, you having night shift? And, we know that night shift really changes your sleeping behaviours and really knocks people about. And I have found that sometimes it can be associated with not as effective weight loss after surgery.
And I regained 40. I put on 40 kilos in sort of 5 years working night shifts at a service station.
Exactly. Because it changes your sleep cycle. You don't know whether it's breakfast or dinner, and you're not really sure what's going on, and your body's not working effectively. It's going to have an impact. And then there's other external factors that are a problem for people. They have a difficult family situation, or they've been through a stressful time, and that can be really challenging because there's not a lot you can do about that sometimes. And then after a period of trying to optimize things, whether that's 3, 6, 9, 12 months, then we look at other interventions, whether that be, medication or surgical. And that's really the stepwise approach.
Yeah. So back to the question about the twisted sleeve.
Yeah.
I think Amanda said it was twisted at the top of my stomach. And now, only 15 weeks later, I'm booked in for a mini bypass.
That makes a little bit more sense. I think that I can't comment with clarity without knowing the clinical situation. It may sound like the actual, like we were talking about before, the sleeve has twisted. And so you're not able to empty your stomach effectively, and that's why you've converted to a bypass, struggling to eat, etc. So I think that sounds like it may be a technical issue potentially, or an anatomical issue, and but I apologise. I struggled. I won't be able to really comment too much more without.
Yeah. And then we've got, how common is reflux after the sleeve?
Yeah, the figures are so variable as to what the actual rates are, and I think there's reflux on a imaging, and there's clinically significant reflux. And I think the reflux that I talk to patients about is clinically significant reflux. So if you get reflux now and then, and it's managed with a pantoprazole, and you are otherwise okay, and it doesn't change your life, and you don't have any esophagitis, so that scarring of your esophagus, then that's going to probably be okay. Whereas if you're getting erosive esophagitis, or really bad irritation of Barrett's esophagus, a lot of changes to the lining of your esophagus, well, that's a whole nother problem, and those issues are less common. But I would say up to 20% of patients can have reflux after a sleeve, maybe even more, maybe up to 50%. But the clinically significant reflux is relatively low, and the conversion rate for reflux, I would say, is less than 10%, maybe less than 5%. but it varies a lot depending on the surgeon and the cohort, because I really try and not perform a sleeve if somebody has reflux. So I'm trying to tease those people
Yep.
out as best I can. Doesn't always work, but I think those figures are relatively low.
Yeah. It's great when all those factors are sort of taken into consideration so that we can make an informed decision.
Absolutely. And there are other things that come into play. So some people can't have a bypass because they're on anti-inflammatories their whole life, or they have asthma flare-ups and they're on prednisolone or something like that. And that makes it tricky as well. So there are.
So while we're on that, Crohn's.
Yeah.
Because that's I know.
Common.
Yes.
Yeah, it's pretty common. So Crohn's can affect different areas of the GI tract. So I think that's the first thing to recognise, is not all patients have Crohn's in their small bowel. Some people have it in their large bowel alone, or wherever it may be, duodenum in particular, things like that. Terminal ileum, maybe not in the entirety of the small bowel. So I think it's important to liaise with the gastroenterologist or whoever the main medical caregiver is for the Crohn's. And you're probably going to have an MRI to assess the inflammation, the areas of inflammation, if they haven't had one already.
Yep.
And go from there. Yeah, but I have performed bypasses on patients with Crohn's. I have.
Okay. Yeah, that's interesting.
Try and sway people towards a sleeve, but it's not 100%.
Yep, I guess, and that again is a case by case. Issue.
Yeah, it depends what their Crohn's is like, and usually the inflammation is a lot better after weight loss.
Yeah.
Yeah.
Big one, dumping.
Yeah.
I didn't realize that it came in so many different sort of types and forms until I experienced it. I think I was 2 weeks post-op, still on liquids, and thought, you know what, I'm going to have a lime thick shake. And that was bad.
Because it's a liquid, and again, it's so variable. Most of the time, a sleeve gastrectomy is going to protect you from dumping or minimize dumping, because you have your pylorus. So you still have a sphincter there that'll open and shut. But if you're unlucky that, the pylorus is open and you've had liquids and they pour down into your small bowel more rapidly than before because you have a smaller stomach, then you may get some symptoms of dumping, but usually it's related to a bypass. Yeah. And usually related to simple carbohydrates or sugars.
Yep. Yes, I know it can. When it hits it.
Yeah, people can feel terrible. They can have hypoglycemias and pass out and be quite unwell from that. In very serious and very rare situations, you can die from that if untreated. Yeah.
Yeah.
If you have a bypass.
Yep. Yeah. I mean, we've seen people that have, ended up with all sorts of injuries because they have collapsed and fallen and, hit their face or whatever. So,
of course, seek advice if you're having issues with hypos and dumping.
Yeah. Yeah, definitely. Hypothyroidism.
Yeah.
I'd never really heard of that until I was married, and my wife's family were all suffering with different forms. And
like any endocrine disorder, it can definitely have an impact on your weight, and it should be treated. Again, that's why it's important to have good people around you. I have an endocrinologist in-house, which is fantastic.
Oh, that's great.
Yeah, particularly useful for patients when they're diabetics on insulin. I find it's really useful just to liaise and have a good plan. But for things like hypothyroidism and hyperparathyroidism and other things, and I think to answer the question, it can impact on your weight loss, and it is something that should be treated prior to surgery as best as possible.
Yeah.
Yeah.
But it's great that there's still that option there, even with it, and again, it's just showing how far we've come, sort of in the last 20 years.
Yeah, I think so.
Constipation. That is a big one.
Common. It's common. Yeah.
Gosh.
It's really common with weight loss medications as well, I have to say. And it's one of the side effects that doesn't really get better. If you're constipated with medication, it's probably not going to resolve as easily as the other side effects. I think if you haven't used your bowels for days to weeks, you have to seek medical attention, and I would be giving you a bowel prep, probably, which I do occasionally or rarely, but it does happen. Yeah, absolutely.
Yeah. We've had that with a family member and spent many nights in hospital doing washouts and all that sort of fun stuff.
Yeah, because you may need enemas as well, and in the worst cases, manual disinfection, which is not pleasant for anybody, really.
No, not at all.
But the prevention is better than the cure.
It is.
On top of it, when it's days, not weeks, that would be the,
I think one of the issues that we faced was once it was all clear, then it was a case of, okay, well, you need to stay on Movicol, Osmomax, for up to 12 months until the bowel really shrinks and everything starts moving again. Whereas we want clear, and then we go,
we're done.
That's great, we're done. I'm not taking Movicol anymore because, no one likes it, but...
No, you got to keep it going. You're absolutely right. Yeah. So.
Yeah. This is a big one. One of our participants just asked, is excess skin removal avoidable by exercise?
Well, if you think about it, nobody has to have excess skin removed, so it's completely avoidable if you don't want to have removed. But I think, I guess, exercise and particular weights training will be your best attempt at minimizing the issues with skin. But sometimes with weight loss, depending on your genetics and where you lose the weight from, and how your skin integrity or turgor is, and what your muscle mass is like, and all of those things, it's unavoidable sometimes. So you can improve upon it definitely with exercise, and particularly weights and other toning or resistance training, but it's not completely unavoidable. Sometimes there's no way around it.
Yeah, I just want to jump in there and just say, I've squatted for 7 years, and my backside still looks like a Shar-Pei. It's just
sometimes it's just where you lose the weight, and it's hard to combat. Yeah,
I think
it's better genetics, is it?
Yeah.
Shar-Peis are cute though. So.
I think it would probably depend. Well, for me, there would have been no way possible for me to tone my stomach enough to lose all of the skin.
Exactly. It's skin. You can't tone skin. It's subcutaneous skin sometimes. Yeah.
So I think, and I've seen some people that work out and they look so incredible after weight loss, and I just look like I'd melted. So yeah, I think it's just so variable, just like you said, Dr. George. I just think
I think it's worth, you want to do your best to minimize from a patient perspective those things, and again it helps with preventing or trying to avoid do your best for weight regain, but at the end of the day these things happen.
Yeah. Now, we spoke briefly earlier about vitamins.
Yes.
And yep, 100%. I agree. I thought it was just a scam when I had my sleeve done and was like, yeah, this dietitian just wants to sell.
Some people have normal blood tests without taking their vitamins, but I would caution against that. It's common to have vitamin deficiencies even with the regular vitamins, and sometimes you need top-ups, and we've seen that time and time again.
Yeah, well, I mean, now I am on regular vitamins and extra other vitamins, and I wish I had have listened earlier. Hindsight's always perfect, but
exactly.
When would you recommend starting taking them after surgery, or is that really a dietitian thing? Or
look, in our practice we usually patients start their vitamins when they get home from hospital, so day 1 or 2, and that's in a chewable or liquid form until they're comfortable with the swallowing, sort of at the transitioning from the puree to the solid phase. But there are no hard and fast rules. Other clinics start vitamins at the 2-week mark, and they'll start on smaller tablets, and that's also fine. I think that's okay. So it's a little bit dependent on what vitamins you're taking and what form they come in. Small tablets, capsules,
horse pills.
Yeah, if they're too big, then obviously you don't want to be having that. You can sometimes crush them, but it just depends. Yeah, open capsules, those kind of things.
Yep. We hear a lot about stretching our stomach, especially after sleeve.
It's a big one.
Yeah. What are your thoughts with that?
Everything in the body stretches.
So it's normal.
It's normal. Everything stretches. I often get it as a reason for wanting a bypass. Sleeve stretch. I say, no, but bypasses stretch too. They're like, everything stretches.
Yep.
Your stomach is never going to stretch or expand back to what it used to be, and having said that, the significant restriction that people have in the first 1 to 2 years will settle down. The restriction will eventually settle down, and you'll be able to eat more, and you'll be able to, you'll feel more hungry. And I think those things are also normal. Hunger is your body's response to wanting to put fuel in, So I think it's all about training routines and positive approaches with food and a positive and healthy lifestyle. That's really the key. But absolutely, your stomach will stretch. That's okay.
Yep. That's what I came to realise. It was okay. I wasn't, so long as I didn't go back to eating the way I used to.
That's right.
I can manage my weight now, and I think that's really what this is about, isn't it? Is weight management.
It's to try and provide a reset for your body and your hormones and your metabolism and your routines and your lifestyle that is positive and approaches weight management in that regard. And it's very, very powerful, and it provides excellent results. It's the best we have at the moment, for sure.
Definitely. Minimizer rings.
Yeah, I saw that. I am very much pro minimizer ring. I probably don't do it enough, to be honest. This is something that I've been thinking about recently. because I saw one of my patients, a few of my patients that I've done a minimizer ring, performed a minimizer ring on. I saw them at their 1 and 2 year appointments, and they have all done exceedingly well, all of them, bar none. They've lost 40, 50+% total body weight loss, and I think I probably don't do it enough. Having said that, there are always some risks, erosions, sometimes difficulty swallowing. So I put, when I place the minimizer ring, so a minimizer ring is a silastic fixed ring. So it basically looks like a circle like this, and it goes on around the pouch of a bypass, and it is fixed. It's not a gastric band. It's not adjustable. It's fixed. So when it's placed in surgery, that's where it is. And it's if you can imagine, there's the pouch, and then the ring goes on loosely. And if somebody eats a large portion of food or too quickly or at one time, it then expands on the ring, and you get that feedback. Otherwise, if you're going about things in a small regular meals and chewing your food, etc., then you shouldn't really know it's there, and that's sort of what patients are telling me. And the benefit of a minimizer ring is really longer term, 5+ years. The weight regain seems to be less, and the weight loss seems to be a little. So it's actually more for longer term outcomes. Yep.
So it keeps you sort of cognizant, I guess, of what you're doing and
of what's happening, and there is some rationale that it keeps the stretch response of the stomach in check. So
okay.
To go back to your other comment, maybe associated with that as well.
Interesting, and obviously safer than a lap band.
Yeah, lap bands are the pits.
Yeah.
Can't tell you enough about how bad they are.
Yeah, I think anyone that has one should automatically be allowed to just go and get it taken out.
I think so, but you do need top gold hospital cover at the moment, which staggers me. But anyway, it's a whole nother discussion.
Yep.
Yeah.
Amazing. I think. Okay. So, and this is probably a very common outcome of weight loss surgery, fertility and pregnancy.
Yeah. So, any particular?
Can having a bypass have a negative effect on pregnancy? And I guess one of the concerns is about getting that nutrition.
I do think you need to keep a very close eye on patients that have a bypass or even a sleeve and that are pregnant. They need different vitamins. They need different nutritional assessments. They need an obstetrician that's understanding of those variations in anatomy and what that means. Patients shouldn't have a glucose tolerance test, things like that.
That wouldn't be fun after bypass.
That'll give you hypos. That'll give you dumping. That's for sure, because that's exactly what you shouldn't do. So, those are some of the really important issues that need to be discussed. And there are others, but also patients need to be changed onto different vitamins, and we're always making sure that the appropriate blood tests are done, and our dietitians really keep a close eye on people with that. In regards to a risk with the pregnancy, I always discuss with patients that there is no, you can have a bypass and have a safe pregnancy and have, a healthy baby, no problems. The only issues arise is if you do have abdominal pain during pregnancy, you need to be assessed. You can still have an internal hernia. you can still have a stomal ulcer. All these things still apply, and that's where we all are worried when younger females have a bypass, and just to make sure that people are aware of this, that it is something that you need to tell your obstetrician. You are potentially at a higher risk during pregnancy, and you need to have that expert opinion and experience around you.
Yeah. And again, I think it just points out the importance of having a team approach.
For sure, yeah. And I rely very heavily on dietitians in the rooms to be up to date with different vitamin, quantities and different particular vitamin sets, and what that means for a patient, whether they're pregnant with this requirement for iron or that requirement for folate, and whatever it may be. I think that's where you're stronger than any one individual.
Yeah, amazing. Dr. George, thank you so much for joining us tonight. I don't think there were any other, or there might have been
there was a question.
Exercise.
The question about lap band removed at the same time as a sleeve or bypass.
Yes.
I guess that's a two-part question. So the answer is yes, you can. A lot of surgeons around Australia perform what's called a single stage revision. I have moved away from that because the complication rates have been shown to be higher with single stage revisions. And also I do like patients to maybe experience what those different swallowing mechanisms are like without a band in place, and going through those sort of preoperative appointments and discussions between the two surgeries. But again, that's a preference, and I understand why people do both ways. But I've taken the road where I try and minimise the complication rates that are for patients. So that's why I do a two-stage revision.
How long would you sort of recommend a person waits? Is that like the 6 week?
It's usually about 8 to 10 weeks. Yeah. Enough time to sort of let everything settle down.
Yeah.
But again, there's no perfect answer to that.
But it's very different, isn't it? Like people go for that band, which has so much restriction, and if you eat too much, it's coming back up. And to even a sleeve or a bypass, you don't get that restriction.
No, it's not like that. Exactly. I think going from, the band to a bypass straight away, I think that's a very different experience to having the band removed, readjusting, and then having a procedure that sort of, helps you to improve those routines. So I think that's sort of the way I've approached things. But, people do single stage revisions effectively, and I've seen that happen. I think the other thing to note is I do not perform a sleeve after a band.
Yes.
I think that has been shown to have less effective weight loss outcomes, higher rates of reflux, and issues regarding, poor outcomes because of that. And I think as a rule, I usually would recommend a bypass after a lap band removal. Yeah.
Great advice. And the last one before we close, how do you exercise if you have shoulder injuries and plantar fasciitis? It's a great question.
It's a great question. That's tricky.
Exercise physiologists. Exactly.
With expert opinion from a professional, I think would be but these are conditions that need to be assessed. And I think, difficult. Plantar fasciitis can be debilitating. I think there are treatments, non-surgical and surgical. Weight loss should help. It may not help soon enough in the acute setting. But but I would seek an expert, whether that's a foot and ankle surgeon or a podiatrist or an exercise physiologist. Yeah.
Amazing.
After a bypass, I think
after bypass.
Weight regain after a bypass, I elect to perform an outlet reduction. So that may not be something that people are familiar with. The outcomes are comparable to any surgical operation, and it's a lot safer for the patient. So an outlet reduction, as it sounds, the junction between the stomach pouch, so the gastrojejunal anastomosis, is sutured through a special endoscopy to be smaller, so the outlet of the stomach to be smaller, and then depending on what the pouch looks like, tapering of the pouch as well, giving you around about 5 to 10% total body weight loss on average, but again, depending on the patient.
Wow.
Lifestyle changes.
Would you have a ring put in at that point?
So the minimizer ring is placed laparoscopically.
Yep.
You could do it, but it's a surgery.
Yep.
Whereas the outlet reduction is a endoscopy.
Just safer and
Just safer endoscopy. Yeah.
Okay.
It's great. It's really been helpful for patients. And like I said, we said it before, sleeve patients and bypass patients are both, are not exempt from weight regain, and it's more about the individual and how you respond to the changes and making those positive routines.
Yeah.
But,
right. Dr. George, thank you so much for joining us tonight. All our guests, we want to thank you for joining us here as well, and we look forward to the next one.
Always a pleasure. Really appreciate it.
Thank you.
Thanks, guys. Cheers.
Thanks.